Hello, I'm Christy Cade with the White Ribbon Alliance.
And I'm Cindy Garcon, Coalition Director of the Self-Care Trailblazers Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone: advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Trailblazers Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee: Advanced Family Planning, JPIGO, PATH, Population Services International, and most of all, White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Welcome and good morning, good afternoon, everyone. And welcome to today's session on the Self-Care Learning and Discovery Series, focused specifically on digital self-care revolution, lessons and opportunities. My name is Tigis Tamrat. I'm a technical officer at the World Health Organization, and I will be co-moderating with my colleague Amnesty. Matt, Amnesty, if you'd like to say a few words.
Thanks so much. We're so thrilled to be here. We've got an all-star lineup for you, kicking off thankfully with Tigis. And just a sort of a brief intro. So I'm a professor at the University of Cape Town and associate faculty at Johns Hopkins School of Public Health. And Tigis and I have been sort of asked to help usher through an all-star lineup of speakers to come. And Tigis, do you want to take us through?
Great, yes. So we have a great mix of speakers, as Amnesty alluded to. We'll be hearing from Patty Michelle at HealthEnabled to talk to us about a digital self-care framework, as well as getting a lot of experiences from the field from Pathfinder Kenya, India, Plan A, Kasha, MDoc, e-commerce, projects in Nigeria, as well as Planned Parenthood. So we're really excited to kick off today and very happy that we have you all join. So just before we start up the session, I'm not sure if we can just project some ground rules and if we can just provide a little bit of an introduction to what this session will be about, as well as if there are some slides that can just speak a little bit to the ground rules. So we'll be having a moderated discussion towards the end, and we'll also try to make sure that there's room for engagement as well as feedback and questions in between sessions. So just to recap, if you have any questions, please feel free to type them into the chat. And my colleague Amnesty and I will be taking a look at that as we go through the sessions.
Just before we start, can we just take a one step back? I know we're a little pressed for time, but just to, on the previous agenda slide, just to kind of note, I know sometimes, longer webinars can feel a little bit over. overwhelming, but we purposely tried to sort of break this into digestible segments. So you'll see Tigist is going to kind of kick us off with an overview of some of the global work WHO has led. We're then going to hear from Patty Michelle, as she mentioned, who's going to give us a sort of a nice contextual framework to give the groundwork for today's session. And we're going to ask you, if you have, sort of burning questions after each of these sessions, just put it in the chat and we'll try and answer it as we go. But we're going to save the majority of sort of Q&A for the sort of last part of the end part of our session. And then, as Tigist mentioned, we're going to have a series of really sort of cool speakers from the field. And each of those sessions are going to be 20 minutes. And to help us kind of get through those so you don't have to hear from us the entire time, we have a number of colleagues that are going to facilitate those discussions as kind of sort of fireside chats. So we have PowerPoint slides that are going to sort of, guide those discussions, but mostly we're sort of hoping they'll be sort of facilitated discussions. And so, Tigist, sorry to interrupt you. Just maybe we'll hand it off back over to you.
No, that sounds great. So we have quite a bit of to cover. So we're going to try to make our way through, and I'll actually be the first speaker. So if Nana, if you're able to put up the slides, or is it just me that's not able to see the slides? Okay, there we go. Great. So just as a background, I work at WHO. I'm the technical officer on digital health and interventions within the Department of Sexual and Reproductive Health and Research, and liaising very much with the Global Digital Health Department and Innovations Unit that has been kicked off at WHO. It's been about a year and a half since that was started. And one of the key things that at WHO has been prioritized is digital health, with the launch of the Global Digital Health Strategy for 2020 to 2025. And essentially the strategy is to improve health for everyone, accelerating the development and adoption of accessible, affordable technologies to prevent, detect, and respond to epidemics and pandemics. And this very much aligns with a lot of the vision as well for why we're using digital health in self-care. So we know that there's an unprecedented amount of use of digital technologies, particularly through the penetration of mobile devices. And this increasingly is becoming used for people to manage their own care, to access information, to be able to look up things, to connect with clinicians and other healthcare providers. And so really seeing that there's a great intersection between digital health and self-care. If we can go to the next slide, please. And within this global digital health strategy, there's 4 different objectives and pillars. So one being on collaboration and knowledge transfer, digital strategy implementation, digital health governance, and next slide, if you can just click on human-centered health systems. And this is where I really think that there's a great confluence between the self-care interventions as well as the self-care interventions as well as the digital health systems, and really trying to bring people to be more empowered and make healthy and health-enabled choices. Next slide, please. One of the ways that WHO has also been trying to promote digital health broadly is through the release of the WHO guideline with recommendations on digital interventions for health system strengthening. This was released in 2019, even prior to the establishment of the WHO Digital Health and Innovations Department. But essentially it was, if you can go to the next slide, please. The objective of this guideline was that at the time there was a lot of enthusiasm, even more so than even though there's more now with COVID, there was a lot of enthusiasm, a lot of people trying to implement digital health, and not really a lot of clarity on the value that digital health interventions, specific digital health interventions, such as text messaging or sending vouchers or doing decision support. There was a lot of questions and skepticism around the value of different digital health tools, and countries and ministries of health really had an interest in including digital health within their overall health system strengthening and programmatic approaches. However, there wasn't really a clear way on how that should go about. And so at WHO, we went through this process of rigorously looking through the evidence base to provide recommendations on different digital health interventions that could really be considered as part of as part of ways to address health system challenges, and also include any implementation considerations, as well as identify evidence and knowledge gaps, which we actually found a lot. While we find digital health to be very promising, and I think a lot of it has been accelerated through COVID, at the time, the evidence base was still kind of a little bit, I would say, ambivalent on the real effectiveness or impact that digital health can bring. But I'm just going to talk you through some of the guideline intervention recommendations that have relevance for self-care recommendations. So if you go to the next slide. So overall, we had about 10 different interventions, and here you can just see that things related to birth notification, to death notification, as well as things in the middle, such as being able to send targeted client communication, more commonly known as well as like text messaging or like sending IVR type of messaging, as well as client to provider telemedicine, making sure that individuals are able to access health workers, making sure that commodities are available. So we had recommendations around stock notification and commodity management, as well as things for quality of care, such as decision support, as well as providing training and educational content to health workers, such as through what people may have heard of as like M-learning or e-learning approaches. And then digital tracking, making sure that there's a record that can help track and identify individuals that need care or know what the status of care is through like a medical record type of approach. And then as well as deaths being notified and accounted for. So for those of you that don't know the guideline, it had quite a range of digital interventions, going from birth to death and all the things in the middle. And it was grounded in the National eHealth, the WHO ITU eHealth Strategy Toolkit. So it was looking at things that are fundamental, such as making sure that there's leadership and governance, making sure that there's a strategy of how the investments would be happening, that there's legislations and regulations and policy and compliance for those, there's workforce, there's the training for the workforce. So we grounded it in all these foundational principles and provided recommendations along these, along different types of interventions that could support the health system, as well as that can help individuals. Next slide, please. So one key recommendation that we had, and believe it or not, this was pre-COVID, was on client to provider telemedicine, where this was recommended, that it helps complement face-to-face delivery of health services and making sure that things like patient safety, the privacy and security, the traceability of, how an encounter happened are able to be monitored or that they're documented in some way. Another recommendation, if you go to the next slide, is relevant for self-care. Next slide, please. Is provider to provider telemedicine. So this is actually telemedicine that can occur between different health workers. So in the context of potentially lower skilled health workers seeking opinions, a second opinion or expert advice from more specialized providers. Next slide, please. And then we also had targeted client communication, where you can actually send information around behavior change or information. This was around sexual, reproductive, maternal, newborn, and child health. And the big thing here was that sensitivity of the content. So for example, in sexual and reproductive health content that was being transmitted, making sure that there's ways to manage that, making sure that people can opt out of it when needed so that it doesn't further compromise individuals. But just, these past few slides of the different recommendations are just to give you a glimpse of what's in here as potentially tools to really support and encourage countries to adopt different types of digital interventions and to really be aware of some of the risks and where the evidence base is for these things so that it's known where they could add value and where the value is slightly something that would, also require additional interventions to be fully effective. You can go to the next slide, please.
Tigas, just to give you a 1-minute warning.
Okay, great. And so this is all within, and then also when the COVID happened, WHO also released additional guidance on how to maintain essential health services. And this is also included within this document where digital health was highlighted as a key pillar for this. Next slide, please. And to complement all this, there's an operational investment guide that can actually help go through a stepwise of how do you implement digital. And I won't go too much into this, but just to say that this is a multi-agency tool that is intended now for us to see how do we actually implement these guidelines and how do we, go through a systematic process of taking digital and incorporating it into a national plan. Next slide, please. And maybe we can go 2 slides down. And lastly, just to kind of bring it back home to why we're here, in the recently released update, the version 2 of the consolidated guideline on self-care interventions, there is still a strong focus on digital, where digital health is seen as a way to promote self-care interventions, offering information, including the client-to-provider telemedicine and other types of interventions that can actually help to implement and evaluate self-care interventions. So I'll stop here, but just the key takeaway is that digital is a core component of a lot of the work that WHO is doing and has been really integrated into the self-care interventions as well as into the general guidance that WHO is putting forth to countries. So thank you, Amnesty. And
yeah, no, Tigas, I think that was a wonderful overview. And I know you might have had to cover, because of time limitations, some of that content at sort of hyper speed. So just to flag that our colleague Sarah has pasted in the chat for those of you that are interested and want more information about this, some of the resource links that Tigas mentioned, and we'll continue to add to that as we go on. So if you want more information, you can find it there. And we'll be having a chance to chat more about this as our session continues. For those of you that have just joined us, please just introduce yourself in the chat. Please feel free to sort of type any questions throughout today's session in the chat as we go. And we really welcome you and are grateful that you've taken the time out of your day to be here. Tigas, shall we introduce our next speaker?
Yes, and I'm very excited to introduce our next speaker, Dr. Patty Michelle, and she'll be joining us today to speak about the global guidance for the digital self-care framework. And just a little background on Patty's, if I can summarize Patty's great history in the digital health space. She's a co-founder and policy lead at HealthEnabled, which is a South African-based nonprofit focused on nationally scaled digital health systems. She has over 20 years of experience working across 40 countries, and she's very well known in this space for most of you that are new to the digital health work, including for her role in the Personal Connected Health Alliance, as well as leading work on the Global Digital Health Index and Maturity, and now the Digital Self-Care Framework. So Patty, really excited to have you on board, and over to you to talk us through the framework.
Great, thanks Tigas, and thanks Amnesty. And thank you everyone, welcome. Really excited about this session as it brings together 2 areas that I'm very passionate about, digital health and self-care. And about 2 years ago, through the support of the Self-Care Trailblazer Group, I had the great fortune to, through HealthEnabled, facilitate the development of a digital self-care framework, which I will talk about now. So if you go to the first slide. So the digital self-care framework really set out to identify the unique benefits of digital self-care. It prioritizes 4 domains critical for design and implementation. And it provides a series of case studies of digital self-care through the lens of sexual and reproductive health, along with a call to action. And this really builds on the foundational work of the WHO guidelines for digital health, as well as the guidelines for self-care, both of which I had the privilege of being involved in, along with TIGIST and Amnesty. And what I want to do in this session is just quickly introduce the framework, and then we are going to move into a facilitated exercise. So think about your digital self-care experience, and we're gonna have an opportunity to share some of that. If you go to the next slide. So the digital self-care framework really builds from the value added from digital self-care interventions. And some of the major value adds are increased access to health services. Digital is prioritized as a point of access to services, increased anonymity and autonomy, that through digital self-care, individuals can engage with health information and health services autonomously and anonymously. That technology and digital technology can provide linkages to healthcare support system as needed, and continuous monitoring of quality and safety, as well as increased ability to monitor and evaluate self-care interventions themselves. And so the four main domains are sort of encased within an iterative design process that are sort of really fueled by the principles for digital development. And for those who don't know those principles, I really encourage you to go learn more about them. They are really foundational to the work that we do. And the four domains are, accountability, responsibility, user experience, quality assurance, and privacy and confidentiality. You go to the next slide. And accountability and responsibility really focuses on the regulatory environment and really making sure that digital self-care interventions are aligned with the enabling environment and the policies and the legal provisions, but that they can also help shape those and bring them into, oftentimes innovation moves faster than the enabling environment, and so bringing those up to speed. Quality assurance, and really making sure that there's a real focus on human rights and safety through reliable linkages to the healthcare system. The user experience, so making sure that the design of digital self-care is really geared towards where individuals are, and how they interact with technology, and also how they interact with the healthcare system, as well as privacy and confidentiality, and a real focus on the major value add of anonymity and autonomy, and really respecting people's need to have their information be private. And so with that, we're going to go into a Jamboard session. Let me put the link into the
Patty, I can do that.
Oh, great. Thanks, Natalia.
Of course. So I can briefly introduce the tool. So everyone, please, in the chat, I will be sending a link to a Jamboard. A Jamboard is a virtual whiteboarding tool. So if you click this link, you'll be able to see this page, which has the image of the matrix, along with 4 different whiteboards for you to contribute to. So each whiteboard has a question, and if you click into one by clicking the image, you'll come to it itself. And on the left-hand side, you can click the sticky note option to simply input your answer here and save to create.
Natalia, just to, sorry, it's Amnesty here. At least on my side, I'm getting a login requirement to the Self-Care Trailblazer Group. Could you just give guidance on how we navigate past that?
Yes, so you should be enrolled in the Trailblazer group, but if you want the direct link to the Jamboard, I sent a second link. The second link will be directly to the Jamboard.
Great, thank you so much.
So please input, and then Patty, I can hand it back to you to talk through these questions.
Yeah, so what I wanted to do was to take a moment to, and this Jamboard will be live throughout the session. So, and I'll be annotating it as we go along, but wanted to get this started as part of the sort of like initial session. But take a moment to share, either one or more of the initiatives that you are working on. That is a digital self-care intervention. And then think about how the intervention that you're sharing about considered the existing, regulations, policies, and legal frameworks. And then and so we'll start here, and then we can quickly move into the other Jamboards, which look at the user experience. So how did the intervention take a person-centered approach? The next one is looking at quality assurance. So in what ways did your intervention prioritize safety, quality, and promote linkages to care? And then the last one is really around privacy and confidentiality. And in what ways did your intervention or the intervention that you're aware of adapt to user comfort levels in sharing information? And so with that, if we go back to the first one, Amnesty, how much more time do we have in this?
Yeah, thanks. So Patty, just to give you, you're almost at 10 minutes.
Okay.
You're at 8 minutes and 30 to be exact.
So we have what, 10 more minutes?
Yeah, 10 more minutes, sorry, about 11.
Wow, I'm like faster than I thought I was like, I'm going to be really efficient. And I think I was. So please, put your information into any parts of this Jamboard that you think are relevant. Or, if you don't feel comfortable using the Jamboard, you can also put your information in the chat, and I can annotate the Jamboard as we go along. We just thought this would be kind of a nice, fun way for people to do something as part of this session, and share their experiences.
So Patty, as an example, my intervention is looking at sending IVR health messages to pregnant and postpartum women. So should I just put a sticky note off to the side that addresses that second question of like the regulations and policies and legal frameworks?
Yep.
Yeah, cool.
That'd be great. This is great. You never know how these things are going to work.
Oh, hard to do interactive work with 100 people, but there we go.
Great. So I'm seeing, folks sharing about interventions aimed to improve access to essential SRH services, digitizing what women want as individuals so that they can share their self-expressed health and rights priorities. Oki is the world's first period tracking and reproductive health education app, together with young people. Nivi has 4 use cases. This is great. Amnesty sending SMS health messages to pregnant and postpartum women. Telemedicine to deliver consultations and product for medical abortion services. MDoc provides user-centered integrated self-care support system for women of reproductive age. Thanks, guys. This is really good, and we'll keep the Jamboard going throughout the session so people can share their experiences. Natalia, do you want to go to the next one? Great. And so maybe people can continue to share sort of in what ways women, users were engaged in the design of the intervention, and or monitoring and providing feedback on the intervention.
I think that second one, Patty, could that also include, some interventions may not include users in the design, as much as I wish that didn't happen. So could this also be as part of evaluations where we ask beneficiaries, what their perspectives are, even if they weren't necessarily involved in the design?
Absolutely. And I think, that we can also be capturing sort of like lessons learned, or even things like, right. I wish we had, sometimes you don't know right. until you kind of come out the other side of it.
Right. Yeah.
Especially when you're working in such a new area, like digital self-care, where everyone is like experimenting as we go along and really testing out to try to figure out like what is going to resonate, what is going to work.
Right.
What's going to fit into people's lives in a way that they're going to want to use it, what's going to be really sticky. One of the biggest challenges that we've seen in mHealth is sustained use of digital health services and how do you keep people like really engaged. And I think in order to do that, people have to be involved. And they have to really derive value from the thing that they're doing.
Yeah, I mean, particularly if it, even if it may not cost you monetarily, it takes your time. In some services it may require data. So there is a cost to you, whether it's an opportunity cost or otherwise. So I agree,
and also think about your own, application use, right? Like, so how many applications have you downloaded and like used once and then like never used again? Or how many like
aspirational, right?
Yeah. Like how many Fitbits have you gotten that, you're like, okay, like after like the charge goes off, then you're sort of like, I'm not going to use it anymore.
I have more Pilates and Mindspace apps that I know what to do with.
There you go.
Many are aspirational apps, but there you go. Yeah.
Great.
So Patty, take us through. So we have user experience here, and I see a lot of our colleagues have come in with some really interesting comments. Maybe take us through the next one, because I know we've got about 5 minutes left. Yeah.
Now, this is great, guys. Thank you so much for sharing your experiences. I think these are super interesting. I love the whole co-creation process. Using relatable language, I think is really, really important. Open-ended questions that, I can't stress enough, allowing people to really share with their own voices what they want and what their experiences are. I think that's like really, really critical and important. We see a lot of that in, medical anthropology, which is sort of my, background. And I think this is great to see, all of these experiences coming through. If we go to the next, piece, here we're really looking at quality assurance. I think one of the major misnomers that we have seen in self-care and digital self-care is that it's meant to be, independent of the healthcare system, and something that came up in the WHO guidelines process, as well as we were doing the digital self-care framework, is that that's not actually true. You have to have like the right levels of, the right linkages to care, the right, safety, quality assurance mechanisms. And, what you're doing needs to be as good as or better than what the standard practice would be.
Mhm.
And so, so I think this is a really important area, and one that I think we're seeing a lot more of a focus on. And some of the platforms, like, I know, MDoc is already, very engaged in sort of these linkages to care, and then really looking at some of these sort of like quality assurance issues.
Yeah, and I think there's sort of really interesting, innovative ways people are starting to kind of use the data generated from the solution itself to kind of comment, to enhance the quality of the services being provided. I saw some of our colleagues, when folks were introducing themselves from MDoc, we have some of the data scientists from their team here. And I'm really excited to hear later on in today's session, perhaps how they've used sort of innovative, the data emanating from this to kind of enhance the services provided.
Great. Yeah, and I think even like in this one, some people are already kind of jumping to the next one, which is more about privacy and security, but we can just do them both here if you like. And then we can make sure that the ones that are related to privacy and security move into the next board. But this is a really incredibly important one. And we've seen some examples of platforms that do not collect any personal identifying information, which I think is really, really interesting, but they're able to still capture information on usage, et cetera, without necessarily having any of the demographic or personal identifiable data to really uphold people's desire to be anonymous, et cetera, when they're using different digital self-care applications and services. And we've seen this especially in the case of like sensitive areas, like HIV, as well as in the case of medical abortion, et cetera, that there is this real need to keep, people's identity private and secure. And so here, it is, some people have done this with unique IDs. Phone sharing is a big challenge and a big issue. And I think that's really important to keep in mind and have account of when designing different, digital self-care interventions, especially in low and middle income countries. And I think also too, in addition to kind of embedding, privacy and security within the technology, someone mentioned having procedures as well that are really, really important. What we found in the privacy and security space is that oftentimes there's a sort of a culture around sharing and talking about things. And so sometimes you have to like reinforce the procedures and the processes related to privacy and security to make sure that people fully understand and appreciate why it is that, we need to make sure to uphold people's personal information.
So, Patty, I've got to stop you. Unfortunately, we're just a minute over,
Okay.
but I wonder if
No
you
worries.
could close us out a little bit, and just to sort of flag if anybody has questions for Patty about the framework, please kind of use the chat here to ask them. We'll take burning questions now, and otherwise we'll hold over questions for the Q&A. Patty, over to you.
So I just want to thank everyone for participating in this exercise. I included in my slides the roadmap from the framework as a reference. So please do take a look at it. It provides a nice sort of laid out process that you can follow. And then there's a link to the framework itself. And I encourage you to use the framework and provide any feedback on your use of the framework so that we can kind of keep track of all of that. So thank you.
Fantastic.
Patty. Yeah, that was really great. And I think you were able to cover a lot of the key themes that we constantly face when introducing and implementing digital health interventions in a very succinct and fun way. So thank you for that. I think now we're going to actually start getting a little bit more into the experiences from the field. The exercise before helped us all to kind of reflect on what we've been doing. And now we're going to hear a little bit more from, some of the implementers that are out there in doing these things in the trenches. So I'll first pass this over to Dr. Preeta Baswas from Pathfinder International to introduce her colleagues and bring us into the session on the role of digital technology into self-care. So Priya, over to you to take on for the session.
Thanks to guest. I hope everyone can hear me. So good morning and good afternoon, everyone. I'm really excited to facilitate the next panel on the use of digital technology in self-care, and also to welcome my colleagues from Pathfinder Kenya and Pathfinder India, who we will be hearing later. So my colleague from Pathfinder Kenya is Dr. Charles Otwori. He is a gynecologist, a medical doctor, but also the technical lead of the USAID Afya Pani project in Kenya. And he is also a senior technical advisor in maternal, newborn, and child health with our Kenya program. He is very experienced with about almost more than 15 years of programming experience in maternal, newborn, and child health, both in the public and the private sectors. So welcome, Charles. I'm really excited to hear from you, your experiences on how you use digital technology to promote self-care in your project. And I think what we'd really like to know from you is, some highlights of your experience. What were some of the challenges that you faced while implementing this project? Because as I understand, you were part of the team that actually conceptualized and deployed these two digital health solutions that you will be talking about. So yes, what were some of the lessons that you learned from implementation, and if you have any recommendations for our audience here? So over to you, Charles.
Thank you, Preeta. Good morning, good afternoon. Thank you for the opportunity to share our experiences in the backdrop of COVID-19. Can you hear me clearly?
Yes, we can hear you.
Yeah, can move to the next slide. The first digital solution is an interactive voice response to address provider bias. We implemented it during the USAID Afya Pani project in Kilifi County, Kenya. The next slide, please. Kilifi County has a high teenage pregnancy of about 21.8%, according to the Kenya Demographic Health Survey of 2014, and a high unmet need for contraceptives among adolescents. Some of the barriers we identified were lack of sexual reproductive health information and provider bias. To address provider bias, we adopted one of the innovative solutions from the Beyond Bias project, that the Binti wa Kisasa. I'll share the link to the learnings for the Binti wa Kisasa project in the chat later. Interactive voice response was a toll-free service with 3 essential functions. Initially, we started with the first function, which was mainly to prime the youth for consultation. It had a pre-recorded message from a young person. The message primed the adolescent on their right and how to overcome provider bias. It also built on the youth negotiation skills. But after piloting that, the youth demanded more. They wanted more information and also linkage to a healthcare provider. And hence we enabled the platform to have 2 other functions. One of it was to provide an option to listening to standard information on the various contraceptives. And lastly, the platform provided an option of talking to a provider to get more information. And this enables connection to the healthcare services, or if the youth had opted for contraceptive or had any other issue to be sorted. Through the platform, we're able to reach about 6,093 young people, with about 47% of them seeking information on contraceptives after the priming message, and 32% wanting a connection to the provider. IVR provides an opportunity to address provider bias, mainstreaming quality-centered care and health promotion through information sharing. Next slide, please. The second is a digital solution to increase awareness and utilization of cervical cancer prevention services. Cervical cancer is a significant cause of mortality in Kenya. It accounts for 9 deaths every day. Yet more than 90% of cervical cancer can be prevented through human papilloma virus vaccination, which was introduced last year for the 10-year-olds, and early screening and treatment of pre-malignant lesions. All these interventions are available in the country. However, utilization is low. We're talking about the screening rate being about 18%, according to the latest, that's the Kenya Demographic Health Survey of 2014. To address this gap in the background of COVID-19, Pathfinder partnered with NIVI to develop and deploy a smart solution to increase awareness and utilization of cervical cancer prevention services in Kilifi and Mombasa County. NIVI uses AI and behavioral science. It works on the premise of giving people the tools necessary to make the right decisions themselves. It provides a digital marketplace where individuals can find health information and services via chatbots that are accessible through Messenger, Facebook Messenger, WhatsApp, and SMS. But for our case, we used Facebook and WhatsApp. Next slide, please. The digital solution applies the principle of behavioral science and leverages AI for personalized engagements to achieve desired health outcomes through Ask NIVI. Ask NIVI focuses on consumers and helps them to achieve their goals through the engage, chat, act model. Data from the engagement also provides insights on knowledge, attitude, and behavior, which are quite useful in the formulation of targeted strategies. Next slide, please. To achieve a critical mass of users and increase uptake of cervical prevention services, we developed a multi-set conversations covering key aspects and issues about cervical cancer and HPV vaccination. We also undertook digital marketing and on-the-ground promotions to raise awareness about cervical cancer and drive uptake of the HPV vaccine. Also, the platform integrated referrals to nearby health facilities that provide cervical cancer screening and HPV vaccinations in the 2 counties. Through the platform, 4,400 clients have onboarded the chatbot and 243 have been referred to the health facilities for service. This digital solution provides an opportunity to leverage social media platforms for health promotion, referral linkages, and are also quite useful for insights. Next slide, please. Despite that, some of the challenges have included having a fixed content, which is pre-programmed, the cost of data bundles, and the need for both basic and smartphones. Sustainability also beyond the programs in terms of site maintenance is also a challenge. However, the major success of these 2 digital solutions has been mainly in providing very comprehensive information. We'll share the link to the NIVI conversation so that you can interact with it and quite see that it's possible to have a lot of information within the chats. And also the real-time feedback and interactive nature of the platforms. Also the friendly use of the social media platform by NIVI and the ability to leverage multiple marketing platforms. Some of the lessons, I think key lesson was this always need to close that gap and connect to the provider so that at the end of it, once the patient has been primed or received that information, they're able to actually get that service, which might not be provided digitally. Hence, there's a need to connect the digital solutions to a 24-hour call center to ensure effective referral. And despite having the interactive digital platforms, at times clients still want direct provider contact, and we should be able to, at the end of it, to close that loop and connect the clients to enable them to get the service. Also, it's important to have a dedicated IT support team to ensure uninterrupted service. Sustainability also needs to be firmed up with sound commitments during the project design. This at times can be a challenge, but should be there so that once clients have onboarded the system, beyond the project, they're able to still benefit from the intervention. Thank you.
So just Preeta, just to give you a time check, you have about 6 minutes remaining.
Right. Thanks, Ussd. So thank you, Charles, for that excellent and very informative presentation. I'd now like to welcome Lakshmi from Pathfinder India to share his experiences from the field, from the project that he's implementing there. Lakshmi, to tell you briefly, is the Senior Director for Social Behavior Change Communication with Pathfinder India. And he has over 15 years of experience in public health communication and specializes in social and behavior change. So Lakshmi, if you could just briefly tell us about how you use digital in the digital approach to promote self-care behavior, self-care seeking behavior or self-care behavior. What were some of the adaptations that you had to do in view of the ongoing COVID pandemic in India? And also some of the limitations that you have observed, as part of your implementation of the digital care approach in your project. Over to you, Lakshmi.
Yeah, thank you, Dr. Preeta, for that introduction. And am I audible enough?
Yes, you are.
Yeah, thank you so much. And it is a privilege, and thank you for this opportunity to share Pathfinder India's YUVA program and various digital interventions that we are doing to promote self-care seeking behavior. Can you go to the first slide, please? So this is a very small deck of 3 slides only, which talks about the YUVA's digital approach to self-care promotion. Talking about YUVA, the next slide, please. So YUVA stands for Youth Voices for Agency and Access. This is one of the flagship family planning program of Pathfinder India being supported by BMGF, and YUVA has two broad primary outcome, that is to improve access and use of contraceptive among newly married couple and the first time parents 15 to 24 age group. And the second is to enable sustainable innovation. The YUVA program is being implemented in 5 selected districts of Maharashtra and Bihar with an estimated reach of 1.2 million target audience, or we can say 600,000 couple. So Maharashtra and Bihar are east and west of the country, which have distinct socio-cultural setting. There are many unique selling proposition of the YUVA program, but in this presentation, I will talk only about the youth social entrepreneurship model and the SBCC intervention. So talking about the digital SBCC intervention, the YUVA program is working towards for shifting the restrictive social and gender norms so that we create an environment where the newly married couples and the first-time parents, especially the women, can have agency and autonomy towards self-care behavior specific to their contraceptive needs. So the YUVA program seed model, it's about a 360 approach to supply side environment and the demand side. The supply side strengthening has been done through a network of private provider who are trained by Pathfinder through various digital platform, including an app-based self-learning tool called Empari, which can be downloaded from in Google from Android and iOS version. There is doorstep service delivery also available to supply site strengthening. YUVA program works very closely with the local government and the key influencer to create an environment where these two other two components, that's the supply side and the demand side, coexist and work in a very coordinated way. Talking about the demand side, there is evidence-based SBCC intervention being carried out across the 10 districts of YUVA program. There is extensive mapping being done by the YUVA car. The mapping exercise primarily is done to collect more information about the target audience so that we approach them in a very customized manner. Then there is in-person telecounseling and digital platform. So in the next slide, I will take you through a storyboard, which will tell you about how the YUVA program is benefiting our target audience. So the storyboard is like this. So click this. So meet Sunita, who is 18 years old, and Mohan, who is 21-year-old. They are newly married and they live in rural Bihar. Currently, they are not using any modern contraceptive, and their knowledge about family planning and contraceptive is very low. Moreover, Sunita is under high pressure to prove her fertility. So at this juncture in their life, next click, please. They meet Yuvakar, the social entrepreneur of YUVA program, and this is where a couple like Sunita and Mohan get introduced to the world of family planning and contraceptive through face-to-face counseling and through telecounseling. Once they get introduced to the system of YUVA through the YUVA car, next please. Sunita and Mohan also have access to various other digital platform of YUVA, like for example, Hello Shuffle, which is a digital IVR platform wherein people like Sunita and Mohan can give a missed call and can have direct access to various communication messaging plays, interactive game tool, which are like under these 5 broad thematic areas. There are about 15 to 20 episodes, audio episode on this IVR where we can listen to, where Sunita and Mohan can listen to any time 24/7. Next slide, please. Next click. Not only this, once they are exposed to the IVR platform, they are also sending reminder messages through various SMSs and OVDs and new prompts about telling them about arrival of new episode in the IVR platform. So that develops a creative anxiety of what's the new episodes are all about. So if you see the whole exposure that people, couple like Sunita and Mohan gets after repeated exposure, Sunita and Mohan show some intention to act, a move towards self-care seeking behavior. So at this point, next click, please.
Just
At this
also,
point in the,
just to indicate that we're over time a little bit, so if you can maybe close or so and we can get into the poll.
Yeah, so at this point, Yuvakar meets them and provide them the end services, thereby closing the loop. Next slide, please. So the mobile numbers are stored in an interactive, in a central server, and we have a next click, and we have a robust MIS system to track the functioning of this entire digital India. So this is the core area of the digital intervention under the UVA program. So next slide and the last slide is talking about the impact. So far, there are about 300,000 TGs being mapped. There are about 400 Yuvakar presently working in the program. 90,000 people have been already counseled and tele-counseled. These people have called the IVR platform and they've listened to the various episodes of 13,500 times, which is approximately 1.4 million seconds of media consumption. There are about 150 private providers. So what has worked well for us in this digital intervention is the inclination of the people towards digital learning. They are more inclined towards knowing about digital interventions, using digital tools. So this is something very interesting. Telecounseling has worked for us. Digital training has worked with us. Social entrepreneurs model has worked for us. And the challenges that you see are typical of any social digital interventions like switching off mobile services, service provided by user, call drop in weak places, tracking TGs due to migration because of the pandemic, and tracking referral due to pandemic. So these are broad challenges that we have. So if you guys want to know more about the UVA project, please scan the QR code here or reach out to the website that is being given.
Thank you.
Thank you. Thank you.
And I think, thank you very much for that presentation. I think now we can quickly go into the poll. We're a little bit over time, but if Natalia, you can, thanks so much. Maybe Preeta, you can let us know about this, this poll.
Yes, thanks to guest. I just wanted to first thank Lakshmi for a wonderful presentation and this wonderful sort of concept of having social entrepreneurs within the youth for the youth to enable their self-care behavior. So I think what I'd like the audience to do is just select one of the options in the poll question, and then we can look at the result at the end. And while you're doing that, I'll just hand over to guest. So over to you, Tigest.
Great, thanks so much, Dr. Preeta, Dr. Charles, as well as Dr. Lakshmi for this presentation. And while we get the poll results started, we can head to the next presentation. So I can.
Great. Yeah.
Great. Amnesty, over to you. Thank you.
Sure. So our next presenters are a team of folks, and our session facilitator is going to be Brent McCann from the Camber Collective. And I'll let Brent introduce our speakers, Moses Wanami and Edna Anab from Kasha. And they're going to be talking to us today about an e-commerce platform, which has been used to deliver contraceptive methods. So over to you, Brent.
Wonderful. Thanks so much, Amnesty. Well, welcome everyone, and certainly excited about this opportunity. Again, my name is Brent McCann. I'm based in Paris and I work for Camber Collective, who is in charge of managing this Plan A project, which we'll get into in just a second here. I'm very excited, along with my colleague Patrick Russell, to facilitate the next panel, and specifically talk about the use of e-commerce platform to deliver a potentially new family planning method, which is this levonorgestrel at 1.5 milligrams for pericoital use. It's a method potentially very well suited to be used as a self-care method. So yeah, so Moses Wanami, who's a consultant for Plan A, who you see there on your screen, and Edna Anab, who is the digital health specialist and health coordinator for Kasha. Kasha was the platform for which the study participants could obtain this study product, levonorgestrel at 1.5 milligrams for pericoital use. She'll be introduced to you shortly and will be presenting as well. And we'll be discussing some elements of the project and the study, some challenges related to use of this e-commerce platform, and the benefits and some lessons learned. Next slide, please. And actually one more slide. Great. So in terms of an agenda specifically, so over the next 15 minutes, we will talk to you on the background, give you a little insights on the background of the Plan A project, and again, specifically this Kenya study, where we use the e-commerce platform. Then we'll get into using the e-commerce platform for the pericoital provision, benefits and some challenges and the ways we mitigated those challenges. And then we will talk about lessons learned. And just as a reminder, please feel free to ask any questions via the chat box. Our team will help. We'll try to answer all those that we can throughout the presentation. And with that, I will pass it over to Moses Wanami. Moses?
Thank you so much, Brent, and sorry for that. Welcome, everyone. My name is Moses, as I've been introduced, working as a consultant based in Nairobi. Plan A project Kenya study, as it has been mentioned, it was a 3-year project to study the acceptability, feasibility of LNG 1.5 for pericoital use. So for Kenya, it has been a 1-year study and funded by Children Investment Foundation, which is SIF, and Bill and Melinda Gates. In Kenya, we've been working with the partners, including Kasha and our Population Council. Next, please. Why LNG 1.5 for pericoital use? In Kenya, there is a need to enhance family planning options. And you realize that unintended pregnancies in Kenya, they range from 926,000. And we also realize that there's a high unmet need for modern contraceptive, which stands at 18.6% in Kenya. High discontinuation rates of contraceptive methods suggest dissatisfaction with available methods. And also infrequent or no sex is commonly cited reasons for the non-use of contraceptives. Therefore, a pericoital contraceptive pill would fill in unmet need and improve choices in the country. Currently, there is no modern contraceptive methods that it's so discreet and can go unnoticed, only when they need it. This is for women in a reproductive age, and also easy to remember. It doesn't interrupt intercourse and appeals to women who have never used contraception and who have infrequent sex. Next, please. Therefore, the study in Kenya was in 3 phases. And phase 1 primarily was thus research and assessment, both qualitative and quantitative interviews. Then from the first phase, it moved to the second phase. And currently we are in the second phase where we had a regulatory approval for the study. Then we had an observational study implementation in Kenya, which has been ongoing since last year, August, and it's coming to an end this August. Then thereafter, it will move now to the final stage, which is analysis and dissemination of the findings. So with that, we've been working with the e-commerce platform of Kasha to enhance the study and looking at the feasibility and acceptability of the e-commerce platform. In that case, I would want to hand over back to Brent so that he can lead us to look at the e-commerce platform. Thank you, Brent.
Great, bye. Thanks, Moses, and a great lead in to Edna, who will be walking us through Kasha's platform and some of the benefits and challenges and lessons learned related to the study and provision of levonorgestrel at 1.5 milligrams. Edna, over to you.
Thank you, Brent and Moses. So Kasha is an e-commerce platform where women have, next slide please. So Kasha is an e-commerce platform where women have access to be able to get the products that they need, both for healthcare and self-care. Kasha is operating currently in Kenya and Rwanda, and we are able to do direct-to-consumer delivery system. And the benefits of using Kasha platform, there is direct-to-consumer confidentiality and swift delivery with convenient and flexible delivery time. Our clients have access to customer care centers and our pharmacies for inquiry. The good thing is the client would have to go to our pharmacy where they have to be faced by asked weird questions by the pharmacist. And the order confirmation is done in language of choice. Either it can be done in Kiswahili or English, but this one depends on what the client prefers. Our clients also have access to our nurse chat and call line. So they have the opportunity of seeking further clarification. And we have both online and offline ordering, where a client who has a basic mobile phone, they can be able to place their order either offline or online version. So in Kasha, we are able to get key metric capture and high level of monitoring of purchase habits. So which was very handy when it comes to evaluating the product usage by the participants. And also there is easy to adapt the order platform and increase demand. Next slide, please. Just like Moses had mentioned, so the main aim of Kasha in this study, we were the sole distributor of the study product, and our participant could be able to purchase the product either via Ussd or either our website, or for some of them, they preferred calling our customer care center to place their order. And then after we received their orders, the product was delivered the next day. And in order to ensure that the clients were not able to misuse the drug or get extra supply, we had limitation in our system where the study participants were able to access a maximum of 6 doses within any period of 30 days. On the left hand is just a snapshot of our delivery system, our order and deliveries process, where after our client places their order, our customer care team are able to call the client to do the verification of the order. Then the call is transferred to the pharmacist, who is able to give the client the instruction on how to use the drug, information about the side effects, and also inform the client where to go to in case they have any side effect for management. And eventually the product is delivered by our rider, who is also trained, who has to ensure that for the new clients, they have signed the consent form in duplicate. One copy is retained by the client and the other copy is brought to us, and eventually is taken to population council. Next slide, please. Oh, so for the Ussd, here we had a short code where the participants, they were able to dial a certain code, and after dialing that code, using their participant ID number and phone number, the system was able to recognize them as a participant, and they were able to place an order in our system. Thank you, Mobison. So to continue, here I just want to take a pause a little bit. And we are glad to hear from you on what do you think are some of the benefits of using an e-commerce platform? And the next one, what do you think are some of the challenges of using an e-commerce platform? We'll really be glad to hear from you. So on the chat box, there is a link which you can be able to click there and share your findings.
So, Edna, I wonder, while we're waiting for folks to go to the chat box and fill out answers to those questions, we had 2 questions in the chat, one from Purti asking why the choice to 6 for a dosage limit. And then we also had a request that you share more on how clients use the Ussd to place the order.
Yep, thanks, Amnesty. I'm happy to jump in too as well. I think Edna may have just answered the second question about how the Ussd process works, but certainly willing to answer to talk more about that if there's additional questions. In terms of 6-dose limit, there was a WHO study by Mario Festin et al. That was done in like 2011 or 2012 that tested, in a similar way, levonorgestrel at 1.5 milligrams for pericoital use. And there were some calculations done based on the amount of hormones in a woman's system at any one point in time. And the limits of use at that point was set at 6 doses per month. And so we used that same logic for the study.
Great. And if you could also maybe elaborate on the question from Genesis about how the contract with nurses work and what sustainability looks like for this project. So as we load up more questions on the Slido, if you can also maybe address this.
Sure. Let me look back through the chat box. I'm not quite fully understanding the question about contracts with nurses.
The contact with nurses. Could you share more about the contact, how the contact with nurses work and what sustainability looks like for this project?
Well, there weren't, we had community health workers involved to recruit women into the study, and community mobilizers as well. And women interacted with pharmacists once they ordered the study product. So each time a woman ordered the study product, she called Kasha's hotline, or she was called by Kasha's hotline. And then she spoke to a study pharmacist about the study product, about how it was used, about potential side effects. And certainly she could call the pharmacist back if she had any questions. Those were the interactions that women had with medical professionals within the study. There wasn't a direct interaction with nurses.
Thanks for that clarification. So just wondering, Natalia, I think we've given people enough time, and this could lead us into the question that Grace asked about, some of the concerns about availability to people in remote sessions. So I think, when talking about some of the challenges of using an e-commerce platform, maybe that would also come up. So perhaps Moses, your team can help walk us through what you're seeing on the Slido results.
Yeah. Thanks very much. I think Edna, we were just gonna, as a team, we're gonna look through those responses, and I appreciate everyone for responding. Looks like proximity to the clients, privacy, discreet and convenient, which is certainly some of the things that we'd heard in the past: increased coverage and acceptability, efficiency. Personal access, no need to travel, delivery rights to one's home. Those are definitely some of the benefits that we also see from Kasha's system. And I'm looking to see if maybe there's answers to the second question and some of the challenges, connectivity issues, cost, certainly lack of smartphones, which is something we get into in lessons learned. So I appreciate that call out. Policy and regulations, lack of interest from e-commerce platforms. Certainly something we saw within the study is that for a lot of women, this was a new way of purchasing anything. Marketing, reaching out to the consumer about the existence of the platform and converting them into users of it. Yes, good call out. Wi-Fi access, technology challenges. Yeah, so a lot of really good feedback from everyone. Maybe in the interest of time, maybe we move on. Edna continues with some of the challenges that we saw within the study.
Thank you. So for some of the challenges that we were able to experience during the study, we noticed that had challenges.
Sorry, Edna, if you could just, your mic is still faint. Yeah, sorry, go ahead.
So for the challenges we noticed were mainly around 3 areas. The first area was around delivery, where sometimes we were able to take the product as we had agreed with the client, but the client was not available to collect the product. And sometimes we had to conduct follow-up calls and contact in order to, just as a follow-up as a follow-up in order to ensure that the product is able to be delivered well. Either the customer care or the pharmacy had to call the client. So sometimes you'll find that the client wasn't available to pick a call either from the pharmacist or the customer care. And the other challenge, initially, while we are coming up with the pathway and the demand, we thought that most of the client might prefer using the website, but this wasn't as what we expected. We found out that actually most of the client preferred using Ussd instead. And trying to look at some of the solutions that we're able to come up with to deal with the challenges. First of all, around delivery, we continued conducting frequently training for our staff and monitoring to ensure that we are able to reduce the chances of orders not delivered. And we were able to launch a bundle pack to decrease delivery frequency. By saying a bundle pack is whereby a client was able to order.
If you can just mute yourself if you're not the speaker, Dr. Ephraim.
Sorry. So our client was able to order 3 doses at once. And also we created expectations during the follow-up calls that the product would be delivered the next day and agree clearly with the client when they prefer for the product to be delivered. And for those clients who are not available to pick our follow-up calls, we work closely with the community members who were able to assist us to trace the client. And once the client was available, we were able to do the delivery. And the other one, we call the client immediately after they place the orders to decrease the chances that the client will not be available when we were delivering. And we also transferred calls from the customer care to the pharmacy to reduce frequent phone calls to the client. And the last one around the user order pathway and demand, we were able to send out frequent SMS nudge to the clients, which was able to prompt the clients to place their orders. Next slide, please. So I want to hand it back to Brand. Thank you.
Yep, thanks so much, Edna. And I'll pass it over to, one more time, I'll pass it over to Patrick, who will finish up.
Hi, everybody. Patrick Russell from Kasha here. Yeah, we just wanted to finish up by rounding out the lessons learned from what you've heard over the last 20 minutes or so. So there's a couple of key points here from the study. First of all, last mile delivery allows for discrete delivery. So this is especially, direct to consumer delivery allows for the discrete delivery. This is especially useful for products that individuals may want to order confidentially, like in the realms of this study. Secondly, it's important to have fast direct to consumer delivery, especially for products needed in the short term, for example, contraceptives. So ensuring that customers can get same day or next day delivery is vital. To avoid order cancellation and other issues, frequent follow-up is important. It's also very important to have offline and online ordering methods. As you've seen from what you've just been shown, the majority of the clients in this study actually ordered through Ussd, which was unexpected at the beginning of the study. And this enables you to reach the widest variety of people from all socio-economic backgrounds. And finally, strong data capture as you move along allows for quick changes in strategy and also adapting the messaging as you move along. That's wrapping up the lessons learned. I've seen there's a few questions in the chat box. I think we have to move quite quickly on to the next session, but we'll be coming back to questions at the end. So I'll just pass, I think, back to Amnesty. Yeah.
Yes, thank you. Thank you to the team, Patrick, Brent, Moses, and Edna. And it looks like a lot of the questions have been addressed on the chat, so that's great. I'm glad that everyone is using that as an opportunity to get the engagement with the panelists. So in the interest of time, we will move forward to the next presentation, but before we do so, we wanted to circle back to the results from the poll that you all took with the first session from Pathfinder. So, wow, great. So it looks like there's a tie almost with data collection and reporting and client education, behavior change communication, and with provider training and telemedicine in some runner-up places. So it looks like there's quite a variety. Ironically, financial transactions and incentives were a bit in the minority, but that's okay. I think Kasha is kind of paving the way there, and perhaps we'll see more in the future. So thank you all again, both the presenters on the e-commerce platform for Kasha, as well as everyone that contributed to this poll results. Just to kind of keep us moving along, we're now going to go to our next session on lessons on using digital technology for SRH programming in the face of the COVID pandemic. And this will be facilitated by Rosalind Ode. So over to you, Rosalind, to give us the overview from your team. Thank you.
Thank you very much. Nice to be with us today. If we could just have the slide up while I do the introductions. So my name is Rosalind Odi, and I work in Abuja, Nigeria at the site for family health as the deputy team lead for the delivery innovations in self-care project. So with me on this call are actually two persons who participated in the COVID adaptation campaign that we ran during the COVID. We have Mr. Ajibola and Ms. Fauziat. Ajibola, by way of introduction, he has 7 years plus experience implementing successful online, offline marketing, and he has worked as marketing lead for a number of global and local brands and managed the highest integrated digital spend in Nigeria. He's currently the head of marketing at Nigeria's largest e-commerce group known as Konga. Fausia, on the other hand, is a public health specialist with 7 years work experience as a social worker in non-profit health sectors. She runs an online forum called Health Communicators to educate thousands on healthy lifestyles and well-being. She's currently working at the site for family health as the country social media engagement coordinator. Thank you both for joining us. So our presentation today will talk about using digital technology to implement SRH in programs in the face of COVID, like have already been mentioned. So by way of background, if I can just have that slide up. Session is looking at what we did. We all know that with COVID-19, there was a huge challenge with accessing sexual reproductive health services as well as products. This was as a result of the lockdown mode with extreme restrictions to movement in the country. This situation, we know, further heightened barriers to accessing contraceptives in Nigeria and putting over 6 million women using a modern contraceptive at risk of not being able to access her refills due to restricted movements. So what we did was to look at what we have, and then with funding from SIF and in partnership with PSI, SFH under the DISC project activated a multi-channel communication campaign through radio and social media, and directly also to existing online shoppers already visiting Konga e-commerce platform to minimize issues of unplanned pregnancies, unsafe abortions, and maternal deaths at the worst that may arise from limited access to SRH products and services. For us, the intervention made use of several channels to drive the process. We had radio adverts, we had health providers' appearances on radio shows, we had program sponsorship, we also had digital and social media posts, sending out messages on SRH, Advice on Facebook, being that is the leading social media platform in our setting. We also had Advice on Konga for product and service provision that was implemented using a helpline operated by a partner organization called Maristops Nigeria, while the products, including free delivery, was basically handled by Konga. The reach of and impact of the intervention was periodically tracked from web analytics generated from different platforms. So to further discuss on these issues are my colleagues, Fauziat and Ajibola. So Fauziat, if you're ready, I think the first prompt goes to you, just to share with us briefly some of the programmatic objectives for the COVID adaptation campaign. Thank you.
Yeah, thank you very much for that beautiful introduction. So to go straight to some of the overall goals and some of the barriers we wanted to mitigate when it comes to access to sexual and reproductive health services. The first one was we wanted to continue to drive continued relevance of contraception for women as an essential service during COVID, and to create a viable space where this can be communicated. We also wanted to create awareness of contraception as a safe and acceptable SRH practice that is endorsed by the Federal Ministry of Health, while we're also addressing the myths and misconceptions related to contraception, especially during the COVID lockdown. Lastly, we wanted to build awareness and to encourage people to purchase from alternative channels for short-term methods, including pharmacies, PPMVs, and e-retail, which is Konga. And I believe this we were able to do during the period of the campaign. Thanks.
Thank you very much. That was very important that we reach consumers with products and services even when they're in lockdown. So my next question is actually to both of you, Ajibola and Fauziat, but I want Ajibola to start off to share with us some of the successes of the interventions, as well as what you think contributed to those successes. Ajibola, if you can take it up from there.
Yes, thank you so much, Rosaline. I'll take this into 4 buckets, which is I'll look at awareness, the awareness leg of the campaign. I'll look at the bit of adoption. I'll also look at the bit of, purchase, which is very important. And I would also look at, the bit of what's it called, the behavioral change, which we're trying to drive also for the campaign. So first off, on awareness standpoint, I know as much as possible, because it was e-commerce driven at the end of the day, being the last destination channel, just on our way to, as much as possible, combat the effects of the, the bottleneck COVID had caused. So I would say from an awareness point of view, the campaign we're able to reach about 7 million plus people across all channels. This is a combination of the online and offline channels that helped in, driving this campaign. From an adoption point of view, I agree with me as much as possible. Because of this campaign, we're able to create and have a category. This campaign forced a category on Konga.com, a standalone category, which we're proud of. And we know what this initiative has been able to help. And also from, if you also want to look at this campaign also from a advocacy point of view, we're also able to drive as much as possible for using influencers, and also we also had radio doing that bit, and also EPR, using, a couple of blogs and websites just to drive consumers from the awareness point of view, enlightenment, advocacy, and also get them to buy. Then finally, when you talk about purchase, as much as possible, we had a conversion rate about 1.1%. So looking at the, the volume of traffic that we drove to the website, those that eventually bought. So there we're able to do about 2,972 purchases from this campaign. And when you look at the sector, health, on health commerce, health when it comes to e-commerce, it's actually very low. It's lower than that. So I would say the campaign, looking at what the channels contributed, we're able to do some very magic numbers. And that's something we're very proud of. Thank you.
Thank you, Ajibola. We know that the site is actually very popular with other things and buying goods, but for health and products, I think it's a great achievement to have that much conversion, even within a short space of about 3 months. So Fauzia, quickly, any other successes from the programmatic point of view?
Yeah, so aside developing a campaign that's centered around self-care is self-love, we're able to empower women to know that there are alternative methods and channels to accessing contraceptives even during the lockdown. We're able to partner with Maristopes International to mainstream a toll-free number where women can access information 24/7 in their safe space, convenient space, and private spaces. We were also able to do partner with several radio stations, about 24 radio stations across the country, to have in-depth chats on family planning methods and contraception, and where listeners are able to call and dial in to get information about contraceptives and also get referred for services even during the lockdown. One of the very interesting things that we were also able to do was to leverage on influencers, which was very innovative because they were able to cut across different geopolitical zones and speak in the languages people understand, and also get our messages across to target populations that were very important to us, both urban and rural women. So those were some of the interventions and successes highlighted from the campaign.
Thank you very much, Fauzia. Just to add that from that campaign, I know that we had over 3,000 calls to the helpline, and some good percentage of that call, 66, was actually for counseling on contraceptives, while 34% was actually to get linkages to health facilities, further buttressing the need that even with self-care, there is still that connection with the formal health sector to drive a more robust approach to health outcomes. Thank you both. We now move on to some of the lessons that we learned, some of the lessons that we generated from this campaign, lessons that can be further explored for self-care intervention using digital space. I would like that Ajibola, you kick that off before we have Fauzia.
And just to chime in here, sorry, just to give you a 9-minute warning. Sorry, go ahead.
That's great. Thank you.
Oh, okay, nice. Yeah, so just quickly, let me just run through that in a minute. So quick challenges of bottlenecks that we had during the campaign. One, I would say cultural differences. You understand Nigeria is a very heterogeneous country where we have so many tribes. And so I felt in terms of communication, we wanted it to be more personalized. And I think together with what we did online, next time we want to have something on ground too, just to match the two, so there's a synergy between the two channels. Two, I would say it's supposed to be an always-on campaign, because you also understand that bulk of this campaign actually aims on what's it called, behavioral change. This is something they are not used to. So to achieve a behavioral change, you need a minimum of 12 to 18 months to be able to achieve that in a particular locality. So as much as possible, we should have an always-on approach to a campaign of this sort. So then that takes me then to a budget factor, which is an extension of campaign extension. Then, finally, then I'll say mobile penetration, which is something we also need to look at next time. Mobile and penetration in the country, which is quite low. Mobile is around 70%, but internet penetration is still around 49-50%. So meaning we can only reach about 5-10 people using online as the only approach or as the only channel to drive such messaging. So yeah, thank you.
Okay, thank you very much. Before you respond, I just want to link what Ajibola just said now to some of the things that I would also need to touch on while you respond to your lessons. Internet penetration quite low, and there is this issue of access to smartphones also. We have a whole lot of women and people who do not have access to smartphone. So when programming, how would you what are the critical considerations that you need to take into account when programming, such that you're able to ensure equity by working to reach people with smartphones versus basic phones?
Thank you very much. So after the campaign, we did a deep dive into learnings as to what actually worked for us during the campaign. And we realized that people in urban areas were able to access our messaging via social media more than people in the urban areas. So while programming for people in the urban areas, we want to factor in the fact that we need to ensure that we are passing same quality information and interventions and not leaving any woman out of our intervention. So which is why this is actually leveraging on the use of IVR for women using basic phones, whereby we're able to leverage on programming for women with basic phones to access information on contraceptives. We want to ensure that even after physical interfacing with people, you are able to have constant supports where you can get information about self-care, where you can get information about contraceptives at your fingertips. So it was very important. It was a very important learning for us during this campaign that we also program for people that does not have access to smartphones and that uses basic phones. So this was highly prioritized.
Awesome. Thank you very much, Fauzia. We'll continue discussions, but at this point, we'd also love to hear from our audience, and we have designed a 2-minute poll for that purpose. So Natalia, kindly help us with that poll so that while that is running, we can then continue to have our discussions. Thank you. Okay, so thank you very much for having done that. Just to go through some of the things that we have here, basically we wanted to find out what you would have done differently and why, if you were to implement something similar that like we just did. So somebody says he or she would like for each step add a non-digital alternative such that those unable and unwilling to contact directly and then keep track of this cost and know who the customer is. Very, very true. We did some of this. We tried to keep track with our customers and then to know who our customers are because we had a human-centered design. We did some analysis on who visits Conga and who would use the social media and all. Just like Fauzia just added, some non-digital alternative came on board based on the lessons that we had from this campaign. All right, another person says I'll emphasize the marketing side of the project, use of online ads. Thank you very much for this comment. That lesson we learned while we were actually working on the project. At some point we knew we needed to push out more ads, and Conga came in really, really handy to do those and just go across different platforms and push those marketing ads, and that increased some of the visibility that we got at the end of the day. Increased awareness of the services, great. Do a survey of potential users, preferred mode of ordering products, and all right, this is great. I mean, programming, you need to iterate and do all kind of things to know what works best. Just to also note that this was at a time where we had the serious COVID restrictions in Nigeria, and we needed to keep people safe while also ensuring that they have access to SRH products and services. Text messaging, chatbots, great. Let's move on, please. Let's scroll up. Let's take 1 or 2 more, then move ahead. Okay, involvement of rural women. Yeah, we actually thought about this, and what we did, maybe not directly, but we a sister project called Sayana Press Scale Up and some other FP programs running in the different states. We try to link them to our call to action and then ensure that there was some level of community-based distribution happening for the project so that people can also have access. So thank you very much for your feedback and for responding to the polls. So we'll just quickly continue and then see how we do before our time runs out. Fauziat, this is to you actually. So self-care approach, we know is very crucial in health empowerment, especially for women and young people. and the marginalized communities. How best do you think digital technology can create that enablement for this much needed empowerment?
Yeah, so basically we realized that digital technology provides a very safe space for women to interact, to learn, and to get access to some services in their convenient space, a private space, and sometimes at no cost of access to information. For example, using a mobile phone, we asked women, what do you want to do, or what do you usually do with your mobile phone, and how can we leverage on it to empower you, to encourage you to self-care, to encourage you to actually practice optimal self-care, and while having the knowledge. So that question actually breeds a lot of programs, interventions that was applied during this campaign. And obviously, continuously, we continue to learn, we continue to partner while avoiding to reinvent the wheel, and we continue to create models or create approaches where women are able to access all of these services and information in a very convenient and safe space at little or no cost.
Thank you very much. Thank you, Fauziat. Sorry to cut in. Any 30 minutes last words from Ajibola before we close this session?
Yeah, so for me, I'll just say as much as possible, this needs to be, we need to extend and make this campaign run more. It's supposed to be an always on effort, but trying to drive a behavioral change. Nigeria is a different country. It's different on this side. So as much as possible, we need to, create a more robust plan, and let's have it run for, an additional few more, about 12 to 18 months. And let's see, then we can practically look at how we've been able to influence and change this number. I saw the feedback from people, and as much as possible, those are things I think we'd also take into consideration, looking at future campaigns, and let's see how we're able to move the needle. But this is something that is a special project for Nigeria, and I think it works, and we're able to, as much as possible, drive impact. Yeah, so that's what I would say. Thank you.
Thank you so much, Fauziat and Ajibola. It was great having both of you on this call. Just to close by reiterating that applying digital technology to healthcare makes provision of healthcare more efficient. And earlier on, when Tigers was talking in her presentation, she made mention of the fact that the COVID pandemic further accelerated growth of health tech industry. And we want to continue to open up the space for innovations as we move along, knowing that through the adoption of digital technology, we can empower health consumers to manage their health and well-being and improve health outcomes. Thank you very much. And that's it for now. We hope to get questions at the end of the other sessions, and we are available to respond to those questions. Thank you.
Thank you so much, Rosalind and team. That was just an excellent presentation. And I really also appreciated how you've been able to answer a lot of the burning questions in the chat, but we hope to come back to you with more sort of intensive questions in our Q&A. So I want to move us along to our next presentation. So we have 2 final sessions left. Each will be about 20 minutes in duration, and then we'll use the remaining time we have for broad questions across the groups. So our next session is going to be led by our colleagues from MDoc, and it's going to talk about experience in providing digital support and building digital literacy. So our session facilitator is going to be Ayupozi, and my apologies, I'll butcher the pronunciation of your last name, so I don't intend to, but if I could just ask you to come in and sort of introduce yourself and your team. And yeah, we look forward to your presentation. Thank you.
Thank you very much, Amnesty. Good day, everyone. Thank you to the moderators and our co-organizers. My name is Ayoposi Obuye, and I'm here with Dr. Kendra Njoku to speak about providing digital self-care support to vulnerable populations in low and middle income countries. Next slide, please. Dr. Kendra is a medical doctor and public health professional who serves as the head of programs and quality lead with MDoc. She leads our digital health solutions and our quality initiatives across several countries. I am a global health professional and an avid researcher who serves as the research and project associate with MDoc. I spearhead our data and evidence generating efforts and also manage projects aimed at increasing access to self-care services. Next slide, please. Yeah, so first we want to find out what do you think are the challenges to providing digital self-care support to vulnerable populations in LMICs. So the facilitators will kindly drop a link to the Slido in the chat, and then you can fill this while the presentation goes on. Oh, you don't have to straight. Okay, thank you. Over to you, Dr. Kendra.
Okay, thank you very much. So we appeal to everyone on the call to please fill this in, and we'll take a look at your answers towards the end of this presentation. And so we at MDoc believe that every individual should truly have their health in their hands anytime, anywhere. Next slide, please. And in introducing MDoc, MDoc is a digital health social enterprise that provides people living with regular health needs and chronic health needs with guidance on self-care and lifestyle modifications so that they can go on to live healthier, happier, more productive lives. We leverage very heavily on quality improvement methodologies, behavioral science, data, and of course, technology. Next slide, please. And so we truly believe that we can leapfrog to achieve our goals by partnering very intentionally with the right organizations. And so you can see a few of our partners on the slide in front of you. And we're also very intentional about, in the next slide, we're also very intentional about contributing to the body of evidence where self-care, the impact of self-care is not vague, but just sharing our implementation experience as we're doing on this call. And so we are very intense about that. Next slide, please. And so in MDoc, we approach providing integrated self-care through a four-pronged high-tech, high-touch approach. The first way we support people with self-care is through our digital platform, our digital self-care platform called Complete Health. Members of the public register and onboard onto the Complete Health platform and are provided with a coach-led multidisciplinary team that supports them on their self-care journey. As Tigest had said, and in line with the WHO digital health guidelines, we do not use our service to replace facility-based care, but look at ourselves as truly complementary to facility-based care. And so our second approach is NaviHealth, which is an online geocoded directory of healthcare workers and health services so that members of the public can go and through this patient navigation to know where to go to seek quality care. The third approach is because we believe in contributing to capacity building, to improving the quality of care within the walls of the facility, we have partnered with University of New Mexico Project ECHO platform over the last 4 years to provide teleeducation to both providers and patients. This was initially just the healthcare providers from 2017, and with the advent of COVID, when the members we support, the public couldn't access health facilities, we started having these virtual classes for members themselves. And just understanding the context within which we work in low, middle income countries, where people still want the in-person, touch with their coaches and with their healthcare providers. We have in-person community-based tech-enabled nudge hubs where the members can come in if they're close to a location that has a hub. They would come in and meet with their coach in person, get support in person, be able to meet in person with their support groups and hold classes in person, nutrition and exercise classes in person. Next slide, please. And so our youngest member is 17 years old. Our oldest member is 94 years old. 89% of our members are women, 71% of them being within the reproductive age. To give some social demographics, you know, our members are majorly low to middle income populations who live less than $3 a day. 67% of them own smartphones. The other 23% either do not have a phone, right? And we have some women who give us their phones, the phone numbers of their husbands, and we communicate through them to them, which, you know, provides that avenue for that family-centered approach, because we're now able to speak to the couple together, while some just have the basic feature phones. Next slide, please. And so we provide care to a variety of members, those living with chronic health needs such as hypertension, diabetes, cancer, obesity, as well as people living with regular health needs. Either they're just men or women on their wellness journey, or women of reproductive health, including pregnant women. So we have partnered with organizations like JPIGO and HSDF, you know, funded on a project funded by MSD for Mothers to provide this service free to women. We understand the cross-cutting nature of health, right? And we believe that self-care should really be cut across whatever that individual is dealing with end to end. And so, you know, because we've seen a lot of intersection between, you know, reproductive health, mental health, and chronic disease. So that holistic self-care, looking at the individual as a whole and not on as a condition or a disease. Next slide, please. And so we truly believe in and have co-created and co-designed our platform with the people that we serve. We have learned that for even those with smartphones, high data cost and low digital literacy make it necessary to have a multimodal, you know, platform, a multimodal experience. And so if you don't have a smartphone, or you have a smartphone and you don't have data, no problem. You don't need to ever download an app. We have a web version. MDoc still works for you, where we believe and we say that our mantra is meeting people where they are. And so we have different and omni-channel approach to providing self-care support. With the support and funding from UK Aid, FCDO, we've been able to, through COVID Action project, we've been able to provide and incorporate Ussd, as well as offline capabilities, some features of the platform that are available without, you know, you can access without needing data, as well as, you know, providing a chat box functionality with conversational design all the time, you know, having this user-centered design approach in deploying all these features. Next slide, please. Okay, and so it's really just this multimodal integrated care approach. We just have like what a typical flow chart is. We have roving ambassadors within the community, markets, schools, malls, healthcare centers, and they go and they onboard these members, teach them how to navigate around the platform. And once they get assigned to a health coach and a multidisciplinary team based on what they pick as their health goals, they opt in, you know, just respecting what they want to address on the platform. They have the option to decide what their health goals are. They are, they are put in groups where they can ask questions and receive health education. The coaches and multidisciplinary team get in touch with them, provide them virtual classes, in-person classes. Most importantly, they're able to track their health metrics on the Complete Health platform. So be it their weight, their blood pressure, their blood glucose, they're able to see their personal dashboards. And a lot of them have told us this is very motivating to see the numbers come down or the numbers go up if it's exercise, as well as receive their personalized, action plans, all the while referring them back to the facility for this, for routine, urgent, and emergent care, as well as providing the tele-education sessions, all get towards healthy and happier members. Next slide, please. And so we're very big on data. And so we run periodic self-efficacy surveys. We've had, a 34% increase to 96%, people saying they feel more confident being able to manage their health and self-care. When asked knowledge-based questions on self-care, chronic disease, we've had greater than 80% scores across the questions. And because just engaging the people, saying, having to even teach the basics, how to join a Zoom class, how to not forget your password or bookmark a page. Those are some of the things that we're able to help members, learn and know. And we've seen that 73% of them say they're more comfortable using their phone for health-related issues than before they joined MDoc. The next slide will just show a snapshot of our data. And, this is just a snapshot of some of our data. We've had over 40 million interactions with greater than 35,000 members. We saw a 10 times increase in our growth since the onset of COVID in March last year. Looking at exercise, at baseline, for lots of people were not exercising. We had a baseline of 23 minutes per week, which increased to 60 minutes post baseline. We know that we're not yet at the WHO recommended 150 to 300 minutes, but we see the progress and we keep pushing for more. Just quickly looking at blood pressure, we see a reduction. We've had a reduction from baseline of 11 millimeter mercury of systolic blood pressure, which we know is significant because a 10 millimeter mercury drop is a 13% decrease in premature mortality, as shared by National Institute of Heart Research. Next slide, please.
Thank you, Dr. Kendra. Now, there is no way that us or our co-organizers would be able to provide digital self-care services if our members or users didn't have trust in us. And we know through our research that building trust can inform the use of our services, and the use of our services can help build our members' trust in us. Next slide, please. So through research and iteration, we work to adapt frameworks to our use. So here is our 3-stage framework for how we build our members' trust in us. The first is the onboarding stage. The next is the nurturing stage, and the third is the Kaizen stage. So I'll just take you stage by stage through our framework. The first stage is the onboarding stage, which happens within the first 48 hours of a member joining our services. So through data analysis, we investigated and we saw that a personalized digital interaction with our health coaches within the first 48 hours of a member joining us was led to higher engagement in our services and also a greater behavioral health change. So this first stage is characterized by a current effect, where like a current, we help our members move towards their goals. We are a convenient, reliable, available, and responsive source of self-care service provision. The next stage after 48 hours is the nurturing stage. This is punctuated by uncomfortable conversations where the coaches let the members know that nothing's off the table, and they are willing and able to talk about any topics. So this trust is built here through talking about maybe topics that would be taboo to talk about in a more general setting. It is also punctuated with uncommon commonalities where the coaches and the members are able to discover that they have things in common with each other that they wouldn't know beforehand. So we saw that a few of our coaches and some of the members had an initial fear of digital technology, and through their interactions, they were able to overcome this fear. It's punctuated with shared vulnerabilities. The coaches are trained to be empathetic and to share with the members without overburdening the members. And it's finally punctuated by an overview effect. So we as a company, we strive to always be switched on. So we know that our members' lives are unpredictable and our coaches' lives are unpredictable, and we are always quick to adapt to any change that we see. The third and final stage is the Kaizen stage. This is a stage of continuous improvement. So we've seen from Amnesty's presentation that there is an iterative design process in designing digital solutions, and user experience is one of the most important one of them. So we take user feedback, and we always make sure that we're trying to improve our services based on the feedback and iterate constantly. So we don't want to be static. We want to be continuously improving our services. Back to you, Dr. Kendra.
And just
thank you very much.
4 more minutes left.
How many more minutes?
4 more minutes.
Okay, great. That sounds okay.
Sorry,
so
Dr. Kendra, just to flag, there's also some questions in the chat. If some of your team could answer them whilst we go. Yes. Over to you, sorry.
Okay, thank you. So we've already started doing that, and we'll get to that while the next presentation goes on. So if we can just go to the next slide to see what we feel are challenges that people face with providing digital self-care support. Okay, so for us, we have the challenges. We've been doing this for 4 years now, and I can tell you that there have been challenges along the way, and we plug the challenges into 3 groups. For infrastructure, right? We know that not everybody owns a smartphone, and that where you do have a smartphone, that you might have a device with low storage that limits your ability to download apps, low battery life, and you pick that because living in low middle income population amongst the low middle income countries, that's the smartphone you can afford. And where you do have a smartphone, there are high cost of data. Or connectivity issues or electricity disruptions. In terms of competency, we've just seen, very low levels of digital literacy, health literacy, and self-efficacy. And there's also the language barriers that happen. With network effects, COVID has helped a lot in removing the bias that digital health does not work. But we've seen a lot of bias even among the healthcare providers. We would have a woman super excited to track her weight, track her blood pressure, and then she goes to the hospital and she's trying to show the health provider her application to say, oh, what are the questions? See my dashboards and all that. And because there's that aversion, it's not happening. And so what are some of the ways that we have dealt with this? With language barriers, we're very intentional about getting coaches who can speak the different languages, right? And who can communicate in the local dialect, both in writing and in speaking. We have messages that go out in Pidgin English, using storytelling, making it more interesting. We've had, next slide, please. In terms of building digital literacy and self-efficacy, we've just used our multimodal approach using voice, generalized messaging, which is automated, personalized messaging, action plans, providing education that is specific to the condition. So do you have a chronic disease? Okay, messages related to that, or are you pregnant? Messages related to your trimester. And incorporating the multidisciplinary team in improving and increasing physical activity and good nutrition.
Thank
In
you.
terms
Just
of
one more
digital-
minute. Yes.
Okay, wrapping up. In terms of digital literacy, we've just had, next slide, please. We've had this multimodal approach as well, just using infographics, how-to videos, virtual walkthroughs, in person, using our community ambassadors and a helpline. So in summary, we know that digital health solutions, next slide, please, the last slide. In summary, we know that digital health solutions work, but to be able to see this transformative change that we want in self-care using digital health solutions, we need an enabling ecosystem. We need to build digital literacy as a first step to having improved health literacy and self-efficacy. We need to partner across industries with mobile network operators, with device manufacturers to drive down the cost of data and the medical devices, as well as even the phones, the smartphones. We need to work with the governments to make sure that we're integrating in a way that is practical and actionable self-care frameworks into national policies. Thank you very much. We'll go to the question, to the chat to answer the questions that are there.
Thank you. Thank you very much for that really great presentation, Iposi and Kendra as well. And just for the interest of time, yes, please go ahead and post your questions in the chat, and the colleagues from NDOC will be there to respond. We'll move quickly in our last 20 minutes for the final presentation from Planned Parenthood on youth access to abortion. So I will hand it off now to Diana to facilitate this last presentation on youth access to abortion. Thank you, and great presentation to MDOC.
Hi, good morning, good afternoon. My name is Diana Santana. I'm a regional director with Planned Parenthood Global. I'd like to welcome you all again to the session to talk about how youth are revolutionizing the use of digital technologies to increase their access to rights-based sexual and reproductive health services. With me today will be Tania Socaraz, Planned Parenthood Global's program manager for Ecuador and Mexico. Tania also leads the expansion of telemedicine for medical abortion in Mexico. And Pilar Montalvo, a senior program officer at Planned Parenthood Global. Pilar is a nurse midwife who has worked with sexual and reproductive health programs in rural areas and with indigenous organizations in Peru, Brazil, and Bolivia. And she supports several organizations in their move to increase access through digital technology. Pilar will be doing her portion of the presentation in Spanish, so just keep that in mind when she's up. Next slide, please. Thank you. Before I continue, I want to reintroduce you to Planned Parenthood Global. Planned Parenthood Global is the international arm of Planned Parenthood Federation of America, or PPFA. This year, we celebrate our 50th anniversary of building civil society and advancing sexual and reproductive health and rights in the countries where we work. Our ultimate goal is true sustainability for our partners and to maintain and create diverse and robust national movements. Instead of providing services or advocating directly in the countries where we work, we provide long-term technical assistance to partners adapted to their individual needs. Because of our model, we're able to innovate and try new approaches. Thank you. Next slide, please. Next slide. The Planned Parenthood vision, and which is foundational to everything we do, is to create a world where every person can choose their own sexual and reproductive path. So in this session, we'll learn about the importance of youth access to digital technologies for information and counseling on rights-based sexual and reproductive health, including abortion, and how youth are leveraging technology to advance self-care for abortion. Next slide. So keeping that in mind, we have a poll question for you. If Lily, I think you can help me. Just answering the question, how comfortable are you in youth engaging in self-care for abortion? We'll give you a few seconds to answer that one question.
So we hope that this presentation helps you feel more comfortable or understand that youth, as our adults, are already engaging in self-care. We must keep in mind the following gaps and challenges when youth seek sexual and reproductive health services, and even more so, abortion services. Next slide, please. And thank you for responding to the poll. I saw that some folks hadn't even thought about this yet, but many already felt comfortable with this. So we're glad to see that. At a macro level, we know that governments fall short on supporting youth access to care. Some, as a result of a growing opposition movement, have reversed or simply not developed rights-based policies. Other barriers include lack of trained healthcare providers, knowledgeable in adolescent health and needs, transport costs, long wait times, and time away from school and other duties. And while talking about barriers is important, I want to talk about the growing movement of youth mobilizing to demand their rights. And these are brave people defending abortion access and demanding that reliable information exists and quality healthcare services are guaranteed by their governments. With the rise of the digital age, there's more information than ever at one's fingertips. And this increased connectivity has given way to an organic rise of youth networks around similar interests and needs. Mobilization is both digital and physical, making a way for a powerful movement of young leaders. Next slide. So how does all of this translate into services models centered on self-care? Fundamentally, at PP Global, we believe youth and adolescents can make responsible and healthy decisions for themselves when they are well-informed and supported. Youth from a very young age have feelings, preferences, express themselves, and it is urgent we break adult-centered models that limit their free determination. For many years, in our experience with the youth peer provider model, we know that youth can be and are a primary source of information, counseling, and referrals to their peers. And that with accurate information and community connections, they can provide direct access to services. The youth-based access to medical abortion, YBAM for short, model incorporates the peer-based and youth-friendly support of a YPP program with the community-based elements of the CBAM, community-based access to misoprostol model, to increase access to safe abortion for and by young people. YBAM is a youth-driven model led by and implemented by youth within their communities. The core idea here is to abandon the idea that medication abortion requires a clinic or even a clinician, and capitalizes on the widespread availability of misoprostol information and pills. With training and support, youth guides and providers are able to offer options counseling and access to misoprostol for abortion, along with contraceptive information and services, follow-up care, and referrals for other services. They ensure information is accurate, support is individualized and appropriate, and services are client-centered and rights-based. Next slide. Given the current context, YBAM guides move their work to the digital space. So now we will ask you the following question. What are the most popular apps among youth looking to obtain information around their health? And as you're responding, I will pass it on to my colleague Pilar. Thank you.
Gracias, Tania. En lo que van respondiendo a la pregunta, podemos ver que hay una gran variedad de aplicaciones y medios digitales que los jóvenes están usando para obtener información respecto a sus diferentes necesidades, entre ellas a la salud sexual y reproductiva, ¿no? Next slide, please. Muchas de estas necesidades y el creciente uso de la tecnología digital ha llevado a que se establezcan y creen nuevas formas de ofrecer y recibir información, consejería y servicios. Por ejemplo, tenemos un servicio de orientación y consejería, que es un modelo que apoyamos en la región de América Latina, donde las necesidades de información oportuna, privada y confiable que tienen los jóvenes es atendida a través de medios digitales, ¿no? A lo largo de los años, y podemos ver en la lámina, a lo largo de los años el canal de atención ha ido adaptándose al avance de la tecnología y a las necesidades de salud de los jóvenes. En el año 1993 teníamos una línea telefónica como única, pero ahora, ahora tenemos el chatbot, que además tiene inteligencia artificial y que es más usada por los jóvenes, ¿no? Como vemos en el gráfico también, un poco más del 50% de jóvenes, son los que usan los diferentes canales y tienen menos de 24 años, ¿no? Respecto a cuáles son los temas que son abordados a través de este servicio de orientación digital, la mayor parte son las consultas sobre métodos anticonceptivos, que incluye la píldora anticonceptiva de emergencia, más de sexualidad, por ejemplo, que están más ligadas al desarrollo del cuerpo, y como tercer tema es el embarazo no deseado, como una consulta que va en crecimiento, ¿no? También otro tema que también ya es abordado por estos canales es el acoso y la violencia sexual. Next, please. Como se mencionó anteriormente, los jóvenes están más conectados entre sí a través del uso de herramientas digitales y usan también para atender sus necesidades o incertidumbres. Además, la situación de confinamiento por el cual estamos viviendo, la pandemia ha hecho que este uso de la tecnología y las redes sociales se incremente para encontrar información y servicios de salud sexual y reproductiva, en los cuales se incluye el tema de aborto. Para esto se han implementado varias estrategias para asegurar que las usuarias tuvieran acceso a estos servicios esenciales, ¿no? Por ejemplo, se aperturó una línea telefónica, desarrollo y mejoramiento de sus redes sociales, la implementación de un servicio a través de WhatsApp o Telegram, apertura de una página de Instagram como un canal de primer contacto para aquellas jóvenes que necesitan un servicio, ¿no? Esas medidas pueden ayudar al incremento del acceso a la información y permiten que las jóvenes puedan tomar decisiones sobre su salud, los servicios que necesitan y cómo acceder de manera confiable y segura. Por ejemplo, la usuaria se acerca al servicio a través de las redes sociales, llama o envía mensajes a la proveedora a través de WhatsApp u otra aplicación, luego la proveedora proporciona información y consejería según las necesidades de la usuaria, da un espacio para tomar su decisión. Si la usuaria decide interrumpir su embarazo, por ejemplo, se manda los medicamentos mediante un servicio de mensajería, o si no, se coordina con la usuaria para establecer la mejor forma de acceder al servicio. Next, please. Estos programas tienen ciertos componentes que son elementales. Primero, el de capacitación, como una acción permanente y colectiva. Las jóvenes proveedoras tienen reuniones activas que permiten intercambiar experiencias, no sentirse solas, sino que se ayudan mutuamente. También se han establecido protocolos, se han desarrollado diversos modelos de servicios que sean seguros, privados, confiables y de calidad, ¿no? Sobre todo pensando en las necesidades de las usuarias. Hacen un trabajo articulado. Las jóvenes proveedoras se articulan entre sí en diferentes regiones y áreas geográficas para hacer referencia de usuarias cuando lo requieren, y también hacen un reporte de datos, es decir, recogen información relevante que les permita ver cuál es la efectividad del programa. Next, please. Entonces, en resumen, podemos ver en esta diapositiva cómo funciona una consulta virtual en la actualidad y cómo las jóvenes hacen uso de este modelo de servicio para el autocuidado, ¿no? Y como decía mi colega Tania también, es que ahora son las jóvenes, están proveyendo información, servicios, consejería, orientación a otras jóvenes, porque ahí es el nexo de la confianza, de tal manera que no haya un usuario que se quede sola sin que forme parte de esta red de jóvenes proveedoras que va en crecimiento en nuestra
Sorry
región.
to interrupt. If Nana or the Tech Change team, can you please move the slides? I believe we're now on slide 91 at least. Is this the correct slide?
No, keep going, please.
Keep going, okay.
Again.
The siguiente. Next. Next. Okay.
Great.
Y en esta lámina podemos ver, por ejemplo, en resumen, cómo es el modelo de la atención a través de los medios digitales y sobre todo centrado en la usuaria, y que además esta usuaria es jóvenes pares como ellos, ¿no? Entonces, en resumen, vemos una gran necesidad de jóvenes respecto a su salud sexual y reproductiva, que incluye aborto seguro y el creciente uso y avance de los medios digitales. Es que en estos modelos de salud deben ir hacia el autocuidado con el uso de la tecnología y centrados en las necesidades de las y los jóvenes. Y te doy la palabra, Tania.
Gracias, Pilar. Next slide, please. So as you've heard from Pilar, the idea of leaving their peers isolated through the pandemic moved many young people to action. In talking with this group of brave young leaders, we have discovered some of the following lessons. One, training provided by healthcare professionals to youth providers strengthens their services and vice versa. Professionals become more sensitive to the specific needs of adolescents and youth, thus creating a support loop. Self-care permits a decentralization of and increased access to abortion. In some countries, differences between state and local laws have limited access for some and facilitated it for others. For women living in the capital, accessing abortion, even within restricted settings, seems to be easier. Whereas for those in provinces or departments away from the capital, access to the service seems to be a challenge. As such, expanding access outside of urban centers across the country is being facilitated by these different self-care programs. As we have seen in the examples above, technology and social media have contributed to an interconnectedness among young people that we have not seen before. This accelerated the creation of regional networks around accompaniment and the support for abortion. And finally, the importance of cybersecurity is key to maintaining confidentiality and privacy for clients and guides. Using apps that are safe and strengthening of knowledge on good computer hygiene is essential. Next slide. We recognize telehealth is not the panacea. COVID has highlighted inequities across the globe. We need to deepen our knowledge on who has access to services and those who are in the most vulnerable positions to co-create innovative solutions and try to resolve some of these inequities. Ideally, the creation and adoption of norms and policies would quickly expand access. But while governments catch up and fulfill their obligations, we hope these examples demonstrate how youth are responding now. Supported by the vision where every person can choose their path to sexual and reproductive health, we hope this session has inspired you to adopt self-care and integrate digital health tools to create a more equitable future for all. And now the final poll. So now that you've learned about some safe and effective models, we want to ask you again, how comfortable are you and youth engaging in self-care for abortion? And as you're responding, I'd like to share the motivating words of one of the providers from the region. She said of her work, "I'm really glad to be part of this change, driven by solidarity and mutual support. These networks will continue to grow and change the lives of millions of women. This has always been the case. However, now it is more accelerated than ever." Thank you, and we're happy to answer questions about the model, etc.
Thank you very much to the presenters for this presentation and really getting into the abortion care done via digital. So we will just stay on for an additional 5 minutes. We're very close to time, but we just want to conclude and get to wrap up things. So if everybody's able to stick around. And here we have the poll results. I don't know if Tanya, if you want to say anything. And then I'll hand off to Amnesty for our concluding remarks and final evaluation.
Thank you for responding. And we see that a lot of people are still very uncomfortable, but we can definitely follow up and you can reach out to us directly if you'd like to discuss it in depth. Thanks.
Thank you. Thank you very much. Amnesty, over to you to close us off And
yeah, thanks. I won't take 5 minutes because I know after sometimes these sessions, we're ready to sort of draw to a close. But I just wanted to take the opportunity to thank our speakers today and thank our audience for sticking with us. We really sort of just are so grateful for the session organizers as well for putting in the time and effort to pull such a divergent group of speakers and organizations together. So I won't recap the full session because we're sort of again out of time. But I do just want to say that I've been sort of widely impressed by the sort of breadth and depth of innovations that are currently being implemented to enhance self-care. We heard about the potential of digital really sort of in a variety of settings. We also heard about a number of concerns, particularly related to sort of equity and access to phones and in particular smartphones. And there were a number of sort of interesting side sort of conversations in the chat about who these programs are reaching. And I was sort of pleased to see that, you know, we've from our speakers have a sort of a wide variety of approaches to enhancing reach, from the Kasha program of providing services direct to beneficiaries to a number of other programs which are providing voice calls direct to beneficiaries that way. And we also heard quite a lot about a number of innovations, in particular MDoc, that is seeking to kind of improve digital literacy. And then we heard some concerns related to sort of data security and privacy, particularly from our last speaker. And, you know, as we sort of take these conversations forward, I encourage you to sort of reach out to our panelists with follow-up questions. And if something didn't get answered in the chat. And we're going to close out today's session with an evaluation. And as our sort of video at the outset announced, this is the first in a series of a number of sessions to come. So we hope you'll continue to attend the forthcoming ones. And with that, I hand it over to our organizers. Thank you very much for having us.
Thank you so much for attending today. If you will find in the chat, you will see a session evaluation form that can also be accessed through our platform. If you have any other questions, you can always feel free to also reach out to the organizers or myself. Thank you all for attending, and please be sure to fill out the session evaluation form.